Answer the call to service. Welcome to the 2018 FNU virtual event. We're celebrating National Midwifery Week. My name is Dr. Jane Houston, and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University. And it gives me so much pleasure to introduce our special guest speaker today, Dawn Thompson. Dawn Thompson is the founder of Improving Birth. She has been in the birth industry since 2003, supporting hundreds of families during the birth and postpartum period. During her work, she witnessed extensive use of non-evidence-based care that was contributing to higher rates of induction, C-sections, and other unnecessary interventions, putting mothers and babies at risk. Not one to stand by, she first organized a small rally at a local San Diego hospital in late 2011, which opened the doors of communication with hospital administration. Then came the national rally to improve birth in 2012, with 110 locations in 46 states, with over 250 media outlets covering this story. Improving Birth has gone on to become the largest consumer advocacy organization in the United States for maternity care. Dawn strives to educate and empower women to take charge of their maternal health decision making and to bring awareness to our maternity care crisis. Dawn, thank you so much for speaking today.
Thank you. Thanks for inviting me to be here. So good morning, good afternoon, depending where you are in the world. I'm so excited to be invited to participate in this way. I think that answering the call to service is an important thing that we often take for granted. And I think that when you're talking about the day-to-day work that you do, I think that the greatest action starts with good communication. And so I'm going to go and just cover some of the things that, as a consumer advocacy organization, we've heard and experienced and have had shared with us about the way people communicate sometimes with pregnant and laboring families. So I think for a lot of things, when I said this quote recently, it really struck home, and it's on our website, on our mother-friendly hospital accreditation program page. But the time has come to turn maternal health care into a conversation rather than a verdict. Medicine has a long history of presupposing what is right for patients. Though it is changing, the paradigm has begun to shift from, in midwifery and nursing and medical schools, from this paternalistic model of doctor knows best to one of shared decision-making. But this new construct still weighs providers' recommendations heavily. In school, you're taught that you possess this knowledge that allows you to delineate the possible paths for your patient, and that ultimately the choice is theirs to make. But even with that shift, it's implicit that there remains one best choice. If the patient doesn't select that choice, then perhaps you didn't do a good enough job of selling them on it. I love, and if you guys haven't read this book, In Shock by Dr. Rana Adish, it's fantastic. It's one of the best read books one of the best books I've read in a very long time. She was critically ill during pregnancy, and she basically, she was a critical care doctor that became a critical care patient. And she really talks about her story, which is incredible. But weaved in all of that is how we could be better communicators with patients. And so I highly recommend this book. Anyways, in her book, she discusses that the medical system trains providers to ask questions that steer people to a destination. They aren't trained to listen and cultivate relationships. Although midwifery, obviously, because it has a different structure in general, does do a better job at this. But in general, when you get into a facility-based practice, you fall prey to the standards, right? So they don't cultivate these relationships, though, through trust and disclosure. And far too often, because of this construct, this unnecessary power struggle ensues between the pregnant families and the providers and staff as they are trying to navigate what the best choice is for them. To listen to patients with a generous ear literally requires a willingness to relinquish control. And to relinquish control is challenging, and it comes with an inherent risk, and it also requires vulnerability, and it's not easy to obtain this. So I want to do just a little disclaimer, though, that before I get really too deep into this, the stories that I'm going to share, I realize are anecdotal. Some of them are extreme. But they are an example of what we've heard from the consumers, and or many of the experiences I'm going to share are my own personal experiences as a doula and as a laboring mother. When we start talking about this, it's never with the purpose to shame anyone, because if there's anything that I have come to appreciate in doing this work, is that I have a lot of empathy for the fact that all people that are working within this medical system are working within a broken system, and that you're struggling a lot of the times just as much as the patients are to navigate it. And so it's never to shame or to if you feel defensive, check in, okay? Check in with yourself, because it's not the purpose or the desire. And I also know that not all providers, not all midwives, not all doctors, not all nurses are going to be guilty of treating people poorly or talking to them inappropriately. So just a little bit more about myself. I'm a mom of 6 kids. We are the true modern day Brady Bunch. We have 3 girls, 3 boys. We are his, hers, and ours. My husband had 2 kids, and I had 2 kids when we got married. They were 4, 6, 7, and 8, and he had majority custody of those children. So we raised 4 of them, and then about 7 years into our marriage, we decided to have a couple more. So I mentioned in my bio that I have that I spent many years as a birth doula and postpartum doula supporting hundreds of families. But before that, I had a PR and marketing background. In both surgical, I worked for a dental implant manufacturer and ran their continuing education department for surgeons. So I had a lot of experience there already working with medical professionals. So, but the thing that this gave me as a doula especially was this opportunity to see birth in all arenas. I saw birth center, I saw home birth, and I attended births in every single hospital in my community. And I believe there's 8 different hospitals. So I had the benefit of not only then working in different facilities, but also working with different providers. And it's amazing the variations from hospital to hospital about policy and standards. And it even varies dramatically sometimes with doctors in the same practice. I'm always amazed how one physician in the same practice as another will have different policies for themselves. And many of them, unfortunately, weren't following best evidence and practices. So it gave me a really, I don't know, I think just a unique view that a lot of doulas, obviously all doulas experience, that sometimes providers and nurses don't get to experience. They don't understand the different variations. And in those variations, it was really clear to see good care and bad care, what evidence-based practices, what patient-centered practices look like. And it wasn't just coming from birth centers and midwives and home birth. It was also coming from providers in hospital environments. So for me, it was really clear that it was possible, right? I could see it clearly that we were in a hospital facility and this was being done. The patient was being respected. Their desires were being considered. They were receiving individualized care, and they were the decision makers in their care. And then on the other hand, I saw every extreme of that. I saw the middle of the road. I saw the absolute extreme of disrespect and abuse in childbirth. And as much as I'd like to go into some of those stories, I think today is not the day. But because of this experience and so traumatic of variations, I started improving birth. I felt really moved that there needed to be more awareness about what was happening with maternity care, that so much of the things that were happening were non-evidence-based. But what everything started coming down to as we got further and further into the road of developing improving birth, I mentioned in the rally that in the bio that we did rallies, and the rallies were really great to raise awareness from a media standpoint. We got a tremendous amount of media attention. Each year, we got around 200 to 250 news articles done. So local news stations running videos, so even inviting some of our coordinators in studio to do events. So we were reaching a lot of people at that time. And it was great. And I think that we did a great job. But our more impactful thing that we did was actually some of the photo campaigns. And this one was our Break the Silence campaign, which was really, really powerful. We got hundreds of submissions. We got tons of text messages and comments and emails, especially when we did the Break the Silence campaign. And the Break the Silence campaign was asking people to tell their story of non-evidence-based and or disrespect in childbirth. And we wound up getting 7 million clicks in just 4 days on this campaign. And that was actually the second time it launched. The first time we got about 1 million, but the second time it hit some major news outlet. I have no idea which one, but it garnered a tremendous amount of attention. And the thing that was surprising to me, and what wound up kind of framing more of the work that we did, was how often people discuss the fact that it was really how they were being spoken to over and over again that made the difference. How their informed consent was violated. They didn't tell me they were about to do that to me. They didn't tell me that they were going to break my water. They didn't tell me, all of these things that when people were talking about the trauma they experienced, so often it was about the fact that people weren't communicating with them in either a respectful manner or with autonomy and informed consent. So I read this article's a great article. I encourage you to read it. Good Patients and Difficult Patients and Rethinking Our Definitions by Louise Aronson. But this quote is, I think, really pertinent, and you can obviously insert, we doctors to we midwives, we nurses do many things that are otherwise unacceptable. We're trained not only in how to do such things, but in how to do them almost without noticing, almost without caring. I want to be really clear that I do not believe that nurses, providers, midwives are going into their work each day thinking, ooh, who can I traumatize today? Like, that's just not the reality. I mean, there's a few outliers that are, pretty abusive and on a regular basis, but to understand that everything within this broken system is grooming providers to believe that they are the boss and that their clinical expertise is the end of the discussion. And that takes me back to my first quote of making medical, not making it a verdict, because so often there's this perception that you're the one that's the boss in the room. And I'd like to just share a realization that I had as a doula that I noticed. When I was going to hospital births and home births, there was this just underlining subconscious difference. And finally, after a few years, I put it together. And that was that when we were going in as support people or providers into a woman's home, we were her guests. right? It's just this subconscious thing. You're walking into her home, you're her guest, and everyone responded appropriately. The mother responded that way, and we responded that way. We had this, just that we were there to help support her through this event. And the opposite was true when we walk into a hospital environment. When you walk into the hospital environment, there's all these rules and procedures and policies, and the woman is now the guest, and she is treated accordingly. And this is where I think a huge disconnect is happening. The reality is that woman walking in, or the family, that person who is birthing, who's walking in, should be treated as if they are the boss. They are the person with the autonomy over this body and over this baby. Because, except for in extreme cases, there is no one who has a greater interest in this baby than she does, than that family does. And we need to put ourselves in a position of finding that to be true. So we know that there's many factors. Oops, I'm back. I got excited there. There are many factors that we know that play into trauma. But the overwhelming reason, like I mentioned before, is that the way people were treated and the way they were spoken to by staff was overwhelmingly what they said was the cause of their trauma. So the studies showed that, or the surveys showed that 33 to 45% of women experience their birth as traumatic. 2 to 17% meet the full PTSD criteria. We all know that birth is difficult. I've seen enough birth, natural, undisturbed birth, that has become traumatic. So to say that if we manage it perfectly, trauma won't be there is just unrealistic. And I don't want to even pretend that that's the case, but we can reduce this number significantly because we are often mistaking the trauma of childbirth with the trauma of the maternity care system. So most people assume, including providers and nurses, that when a patient signs those consent forms when they come in, that they've just signed their life away, that we can do anything to them. And this simply is not true. The patient always has the right to informed consent and the right of refusal. And I think that's really important, the right of refusal, because for any, the right of refusal for any procedure. And ACOG's got a great statement about it that I encourage you to look at if you haven't read it, but it's an important thing. So informed consent, I put these things here. You could just get an idea, because these are all things I can recount. I can recount many instances where I witnessed a patient during a vaginal exam asking for the exam to stop. And the provider unintentionally, totally focused on the job at hand, says something like, "Oh, just one more second. Just let me finish." And sometimes they would even validate her feelings and say, "I know this is uncomfortable, but I just have to do this." My own provider during my vaginal birth, I had a vaginal birth after 3 cesareans. And he did just that. This is a person I trusted immensely. And he was along with my midwife. They were practicing together. And my providers were so focused, I think, on the outcome that here I was after 3 C-sections. They were rooting me on and they could see the baby's head. I had had a lip for a long time and I was having excruciating back labor. And I begged for them to help me do something different. And they were going to, push the cervix back, help push it back, because I was 9 centimeters with the lip. And I had been that way for quite some time. And so they started doing that, but I started, when it started, I started pushing, and the searing pain was unbelievable. And it was beyond, he had pushed my cervix back, which was fine, but this searing pain, and I started screaming and begging him to stop. And everyone around me was just cheering, like, come on, we can see the baby's coming. And I pushed him out very rapidly. He went from a 0 station to out in just 3 pushes. So I literally blew out my entire bottom. They didn't realize that I was prolapsing everything in that moment. I prolapsed my rectum, my urethra, and my bladder. So much so that it required full reconstructive surgery a year later. My providers never intended to hurt me. They were excited. They were engaged. They were all of those things. But I said, stop. And I said, stop several times. And I think that it's important to understand is that when you are doing a vaginal exam and someone says stop or no or any of those things, it's an immediate stop, because so many women wind up being traumatized from an event like that. And and then if they ask you to stop, this is an important part, because I've seen it happen where women are over the top and the provider does pull back, but then the provider treats that woman with, they don't hide their disappointment or their aggravation very well. And now this woman is made to feel less than, or made to feel like she's being difficult because she's asking someone to stop. It's always a good rule of thumb that if she says stop or she says no, that we just respect that. And I understand that you have a job to do, and I understand that there are protocols, but when someone says stop, there is no protocols, be damned, right? We need to stop and acknowledge her and regroup and figure out what's happening in a way that we can support her and make her feel safer and more and protected and feel okay with doing that exam or looking for other options other than that exam. Sorry, that was a heavy one. Heavy for me, so it's a big story to share. And I think this is really, I hope this is a quote that you'll take with you. There should never be a risk to a patient that says, this is what I want. And often that's what happens, is if it is outside of your realm of what you think is right, we often treat women disrespectfully and make them feel, like I said, make them feel less than. And if you're feeling that way, I encourage you to really check in with yourself. If you're feeling annoyed and frustrated by this patient, it's time to step away and check yourself. Check in with yourself. Have you eaten? Are you hungry? Are you tired? Are you, like whatever it is. Also, I'm going to go over some other things too with that, but I will, but be sure to just check in with yourself. So I'd like to talk about shared decision-making. This is the definition for shared decision-making. I'm sure that you know it, but I wanted to share, human rights lawyer Hermine Hayes-Klein spoke a couple years ago at Cedars-Sinai in Los Angeles about shared decision-making, because I think we often have a skewed idea of what shared decision-making really is and what it should look like. The video was recorded on my phone, so please forgive me. It's not the best quality, but the points that she make in this clip is, I think, really important and something that I hope you'll take with you.
Decision making, what is it? And we've seen some definitions go up there today. And I think that something that it's important to establish early in this discussion is that shared decision making as a concept is resting on a legal concept of informed consent and refusal that exists despite the way we might talk about it in terms of shared decision making. The fact is, informed consent and refusal, which is based on the human right to autonomy and the right to make decisions about our bodies, is the law, right? And so that means the patient gets to make the decisions about their care. If we're talking about whether the patient is going to accept an intervention that's being recommended by the provider at the end of this discussion that they're having with their provider. At the end of that conversation, the decision is not shared. And some of those definitions up there almost imply that it was. It was, like the patient, the doctor and patient make the decision together, and then there was one that, then doctor evaluates the patient's decision. There was a reference to the fact that it's the patient's decision, but what do you mean evaluate that decision? So I think that what's worth bearing in mind is the fact that this rhetoric of shared decision making is emerging on top of some questions about the role of informed consent and refusal in obstetric care. So I thought this was an interesting discussion of shared decision making from cancer.org, a website about cancer, because it was trying to say, well, how is this different from informed consent? And they say, well, in both shared decision making and informed consent, you, the patient to whom they're speaking on this website, get information about treatment and you get to make the final decision about the treatment. But what is shared decision making? A newer way of talking about it. It works like this. The doctor gives the patient information about the pros and cons of all the treatment options, including no treatment. The patient tells the doctor about factors that might make each treatment option better or worse than the others for that patient. It says this is quite different from saying yes or no. But what they've described there in shared decision making is informed consent and refusal as it's supposed to operate. So the way that informed consent and refusal is supposed to operate, and it's always described this way by judges when they write about it in cases, is that the practitioner has a duty, a legal duty and an ethical obligation to use their clinical expertise to assess the situation and then to inform the patient about what they perceive their clinical condition to be. So I'll move on to this sort of three-pronged process of informed consent and refusal, which really shared decision-making is supposed to encapsulate simply by highlighting that it's supposed to be a conversation and not just a signature on a form. It's not just a yes or no, will you do this, sign the form, but it's supposed to be a process. And what that process is supposed to involve is that first the practitioner informs the patient. What do they see their clinical situation to be at this point? What do they see their options to be, their clinical options, including the risks and benefits of each of those options and the risks and benefits of doing nothing? And then, a way to think about this first prong is that this is the sort of objective information. This is the objective aspect of the doctor's work or the provider's work, that they're sort of giving them this objective information. Here's your clinical situation, here's your options, here are the known benefits and risks of those options for you. And then the second prong is the prong where the provider can really be subjective. And I think it can be helpful for practitioners to separate this out in their mind. Here's the information, and now here's my advice to you. I see your picture, and here's what I think is going to be the best course of action for you and your baby, if you're dealing with a pregnant patient. And then the third prong has to be to support that patient in making the decision about their care, because it is their decision. And that has to include the opportunity to go against the provider's advice. So that's where the issues come up with shared decision making and informed consent. Informed consent and refusal is only tested as a right in those cases where the patient chooses to resist, question, or go against their provider's advice. And that's when the dynamic is going to be tested for the practitioner, and is going to come into play in that conversation with the patient. And in those situations, often the practitioner can really feel strongly that what it is that they are advising is the best course of action. But informed consent and refusal reminds them to bear in mind all of the variables and values that the patient is bringing into that decision, and to respect the autonomy right of that patient to make the final decision about their care.
So I think it's important, what Hermine is addressing here. I love the cancer organization description, because isn't it true? Like we've all known someone who has cancer, and I think about my grandfather and the fact that when they discovered he had cancer, he was already stage 4, and he was in the hospital in agony, broken a rib because the cancer was in his ribs, and they came in and they said, these are your options. Here we can do treatment, we can do this, we can do that. There's different kinds of treatment, or you could do nothing. And here's the amount of time we think that you'll have if you do these things. And in those moments, my grandfather I laid with him and we decided together, we talked about it together. And he said, I don't want to do anything. And he made that choice and he died just 5 weeks later. But he was respected 100%. They never came in and tried to convince him to do something else, even though their initial recommendation was that he do treatment, that he could get another full year of good life and a year to 2 years. And even though they said that, felt that that was the better choice, or that was their suggested choice to route of action, he chose not to do anything. And we don't do the same thing for women in labor. And I get that it's because there is a baby on board, and I understand that. But again, the chance that we have a greater interest in this baby than they do is not realistic. It's not appropriate for us to put ourselves in that position. It is up to us to give people the full information to help them make the best decision for them. According to this Institute of Healthcare Excellence and the professional research consultants, the number one thing that patients said that they wanted was to be respected and listened to carefully. So let's face it, though, sometimes when we don't agree with someone's decision making, we aren't always good at hiding it, right? We even turn potentially to undermining and sometimes even condescending in our speech. This is true in childbirth. We do it day to day, and it's really easy to do in a stressful situation. But understanding that how you speak to someone has a massive impact on that family's experience of their birth. Understanding how patient experience impacts quality, safety, and efficiency is super important. It's really about how you show up to work each day and the conversations between your patients and between each other. Consumers are looking for transformation from a provider-centered approach to that patient-centered, team-based approach. Although physicians and caregivers work in teams, each and every decision often is not made with the consideration of the patient's perspective. And putting the patient in the center of every decision will improve their experience of birth as well as their outcomes. And we know this to be true. By focusing on communication skills that foster presence and mindfulness, reflective listening, efficient gathering of accurate information, and connecting with patients and each other, by being able to recognize emotions and responding appropriately, we can literally close this gap between what patients want and what they're receiving. And you hold that power in your hands. And the communication is so important. So I'm talking here about what coercion looks like, because I'm going to go over coercion, undermining, and misinformation, because it happens so often. And these are things that I've experienced personally. So if you don't let me check your dilation, I can't continue care with you. This is during a patient's 39-week appointment when she said she didn't need or want a vaginal exam. The placenta stops working after 40 weeks, so your baby won't be getting any more nutrients. We must induce before your due date. This was a low risk first-time mom, young first-time mom. Since you did IVF, if you aren't induced at 40 weeks, your baby will probably die. You worked so hard for him. This was said to one of my clients. She had gone through IVF, and I know what he was referring to was the fact that often IVF patients have a difficult time going into labor. But the way that he communicated this with her was beyond inappropriate and certainly would go in the lines of coerciveness. So, no, the vacuum won't harm your baby at all. It's perfectly safe. The doctor never indicated that the baby was in distress and recommended a vacuum after only 40 minutes of pushing. The baby wound up with a significantly large hematoma on her head. And as you can imagine, that mom was devastated because she said, if I would have known that that's what was going to happen to my baby, I would have never said yes. Sorry, one more. Your cervix is posterior and closed, so we need to schedule a cesarean. You won't be able to have a vaginal delivery. This is during a 38-week prenatal visit. We get this one often. This one's a big one, and it comes in, I'm using quotes right now, obviously, but this comes in many different forms. If you attempt to come in for a TOLAC, a trial of labor after cesarean, we'll call protective services. This is from a mother, by all accounts, was rated high on the VBAC calculator. She had gone to 10 centimeters, pushed for in her previous birth, and she was refused a VBAC because her provider and her hospital just didn't provide VBAC support. And because she was saying I don't want mandatory surgery. I get to choose. The law says I get to choose. And instead they threatened her with child protective services if she came in, waited, because she'd said she'd wait until labor started. And they said, I will call child protective services if you show up here. So undermining can be just as challenging, especially with someone who may not be as confident. You have a birth plan. Birth plans equal cesarean. I can't tell you how many times I've seen staff, nurses mostly, who, a woman comes in with a birth plan and immediately there's the eye rolling. And I've heard nurses at the nurses station making comments like this: "Oh, she should just get the cesarean forms ready." Those kinds of attitudes and bias affect a woman's ability to have a positive birth experience. And remembering that your bias comes into the room with you, whether you think it does or not. So you realize you're here just for a trial of labor, right? You're likely not going to have another cesarean. Or how about, people don't actually have VBACs around here. Why are you doing this to yourself? You aren't getting a gold star or anything. I'm going to share my story in a minute, but those three in the middle were actually said to me during my childbirth. And then, the bed's right outside. You can read through those, but you get the point, I think. So during my second birth, I had a labor, my first one, I was failure to progress. But in the end, when I looked at all my records, I think, and learned more about the maternity care system, it was a failure to wait situation, and I had a C-section. And I was determined to not have a C-section the next time. Although I didn't really educate myself. I didn't go to VBAC classes. I didn't really gather information. I just expected that I would go into labor, and this time I wouldn't go in to the hospital so early, and I would do all these things differently. But in the end, the first thing she said when I walked in was, and I was in full-blown labor. She's like, you realize, you're just here for a trial of labor. Like, people don't actually have cesareans around here or VBACs around here. And, you're just going to have another cesarean. And this nurse said multiple things to me like this throughout, and including the gold star comment. And I wasn't unreasonable. And in fact, I think I was having severe back labor. I was definitely in a lot of pain. And at this time, it was 1997. And they made you stay in bed. You could not get up and move around. You had to be on the monitor 100% of the time. And there I was laying flat on my back, struggling like crazy with back labor. And so I think that I was definitely vocal, and I was definitely stressed and upset. But I don't think it gave any permission for this kind of disrespect and I don't know, it was just disrespect, I guess. But, I think the important thing is that ultimately I finally agreed to a cesarean, and I had what they call classic disassociation. I do not remember the delivery of my son. The last thing I remember was telling them to cut me open. And I have no memory of his delivery. I have no memory. I know that I was separated from him for about 4 hours, but I have no recollection of that. I do not have any memory of anything until 5 days later, after his birth. And it's been 21 years. And that's all I have. That's all I have from his birth. And I honestly didn't associate it with trauma until I started doing this work. That the reason that I had this disassociation was because I was so traumatized, and I felt broken. I felt like I was just pathetic, to be honest with you. And that nurse had the opportunity to change that experience for me and to make it a more positive one, even if she didn't think that I was going to have a VBAC. It would have made all the difference if I would have had people more supportive around me who were birth professionals. So, I guess, some communication tips. I've said a little bit here and there, but being respectful and compassionate. If you feel threatened by the patient choice, again, step out, step away, check in with yourself, and work to try and come from a place of empathy. Be collaborative. Don't turn decision-making into a power struggle. Don't attempt to pull rank over them with this I know better approach. Try to listen with an open mindset, with this intention to help them. And be curious. It offers an opportunity to understand and improve care. Talk to them, ask questions, really engage in what it is that what their goals are, what their personal feelings are, and I'm trying to think of a word and it's not coming to me, but you get the point. I think it's also important to validate their pain, validate their experience, validate their fear, their reality of what is happening. Because listening matters. Actively listening to patients conveys respect of their self-knowledge, and it builds trust. It allows physicians and midwives and nurses to assume the role of the trusted intermediary who not only provides relevant medical knowledge, but also translates it into options in line with the patient's own stated values and priorities. It's only through shared knowledge transmitted in both directions, between the physician and the patient, that we can create an authentic, viable plan and experience for people. That is in the wrong spot. Anyway, so, our first step to advocacy is good communication, I guess. And I think that it's important to start reimagining the roles. And I love, this is a piece written by Dr. Oddish. And although she's talking about physicians in not just childbirth, but any clinical setting, I think it's such a great point. And I'm just going to read it. Behind time pressures, the typically unquestioned roles that physicians and patients assume also inhabit relationship building. In their medical training, physicians often are taught to maintain clinical distance and an even temperament. They are warned not to get too close to patients, lest they internalize the suffering and shoulder it themselves. The best physicians we know reject this advice, and we know midwives usually reject this advice, because it diminishes their humanity and disadvantages their patients who need more than a highly qualified body technician, especially when they're seriously ill or giving birth. Most physicians certainly don't want patients to feel like hostages, but the patients often do. When patients feel like hostages, the ideal of shared decision-making is a pipe dream. Patients learn roles too. They adhere to the doctor's plan, squelch errant thoughts that might sound foolish. Don't ask too many questions, defer to the expert, be a good patient. We show that many patients, especially those with serious disease, behave like hostages in the presence of physicians, unwilling to challenge authority, understating their concerns, and requesting less than they desire. So I want to just put this piece in here that this is where this power struggle is happening, because we're getting to this place where, and by the way, that piece on reimagining roles was in the Harvard Business Review, if anybody wants to go look at it. But the patients are starting to really change this dynamic. They're starting to engage in this shared decision making, but we haven't yet adjusted the hierarchy, right? That we haven't adjusted that that the doctor knows best mentality. So there's this thing that's happening, and I believe it's really a shift that's happening. It's really a shift. And when the provider and the patient join voices, the team dynamic dismantles the harmful hierarchy, like this hierarchy that's happening. And patients and providers are just learning to navigate this complex shift. And that's exactly what it is. It's this complex shift from doctor knows best, or midwife knows best, provider knows best, however you want to say it, to shared decision-making and informed consent. Where we need to work more diligently, though, is not viewing this shift as an insult to one's clinical expertise, but as an opportunity for true individualized care that respects a family's personal values, desires, and goals. And that's what I want to leave you with, is that the goal should be individualized care. And we need to start communicating. We need to start asking questions and really be engaged with people. And if they don't, like I think what in Hermine's video, we can't be bullies when people don't do what we think they should do. We need to be encouraging and supportive and do our very best. We're never going to get it right 100% of the time. It's not going to happen. We're human beings. We're all making mistakes. But we can make birth better starting right now with good communication. So thank you so much. Again, my name is Dawn Thompson, and I'm the president and founder of Improving Birth. You can find us at improvingbirth.org. And if you have any questions or comments about what I had to say today, please feel free to email me at either dawn.thompson@improvingbirth.org, or you can fill out our contact form on the website. Thank you so much for your time today, and I hope that you take some nuggets with you. Thanks.